Hi, everyone, and welcome to the Academics Anonymous podcast. My name is Miguel, and today we are going to be doing another episode in our Hurdles in Healthcare series. So, today we are going to be looking at specifically the female health gap. And to start, I want to go ahead and define the term social determinants of health for you all again. So, a social determinant of health, they are conditions in the environment where people are born, live, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So that's from the US Department of Health and Human Services. There are several different categories that are included within the social determinants of health. That includes economic stability, education quality and access, healthcare quality and access, neighborhood and built environment, and social and community context. We, like I said, are going to be focusing on the female health gap. So there are several things that I want to preface this episode with. To start, this issue, like many of the other issues I'm going to be discussing in the series, include multiple different facets of political, social, economic, and societal factors that I won't be able to discuss in just this one short episode. So if you all are interested in learning more about these topics, go ahead and let me know in the comment section, and we can do an even deeper dive into one of these topics if you'd like. Moreover, this issue has both biological and gender components to it. So when you are listening to the things that I mentioned in this episode, please practice some discretion with how it relates to you or the people around you. This episode is going to attempt to discuss several central themes. We are going to start by addressing the disparity in research, then moving on to this disparity in terms of healthcare. And finally, we're going to be discussing some of the solutions as well as additional resources that you can use to get your own research done on this particular topic if you're interested. So I want to start by talking about some of the videos that I was using to create this episode. And the first two videos were from a TEDx talk at the Woodland Lane Women's Conference that discussed issues of research and healthcare for women, as well as some possible solutions to these issues. And there's two talks. They're going to be linked in the description. The first one is What If Your Symptoms Aren't Normal by Yasmin Baba. And the second one, Advancing Women's Health Equity by Dr. Vinu Babu. The last video that I want to mention is going to be one that's published in the New England Journal of Medicine. This is called Sex, Gender, and Sexuality in the Journal. And this is a transcript of a presentation that was given by a group of historians that were commissioned to review articles published by the New England Journal of Medicine and report on the mistreatment of groups based upon sex, gender, and sexuality. It's a really interesting video that you can go ahead and watch. It's very long. It's about an hour, 20 minutes. So you could put it on 2x speed and listen to it. And it presents some really vital information with regards to academia's historical perspective towards underrepresented groups. So I thought that that was a really interesting watch. If you're interested, you can go ahead and click that link down in the description as well. So we can go ahead and start by getting into the articles for this episode. Okay. So the first article we're going to be looking at is titled The Underrepresentation and Stagnation of Females, Black, and Hispanic Authorship in the Journal of the American Medical Association and New England Journal of Medicine. So this article discusses the lack of presence of people from certain different demographics in two of the most popular medical journals. That includes JAMA and NEJM. Those are the acronyms for the Journal of American Medical Association and the New England Journal of Medicine, respectively. So for this particular article, the researchers looked at studies that were published from 1990 to 2020, and they looked at the research to see whether or not they included female first or last authors. And I just want to go ahead and quickly define these terms. So a first author is the very first name that's listed on a research article, and it's a person that is recognized for making the greatest contribution to the research paper. And then the last name that you see on research papers are typically going to be the person that's recognized for overseeing the project. And that's usually going to be a principal investigator or a supervisor. And so they went ahead and counted all the people that were first and last authors in these research articles And they found that at its peak in 2002, the New England Journal of Medicine had females account for about 28.2% of all of its first authors. And they also found that the rate of increase of this value has been so slow that it would take over 700 years for NEJM to have an even 50-50 split in authorship. So I think that what this really brings up is an issue with support. There isn't sufficient amounts of support for female authors and female researchers to publish in these prominent journals. And that, I think, leads on very well into the next two articles I wanted to introduce you all to. So the first one is Why We Know So Little About Women's Health. That was published in the AAMC. The second one is The Enrollment of Female Participants in United States Drug and Device Phase 1 to 3 clinical trials between 2016 and 2019. And these two articles talk about the lack of enrollment of female participants in research. So to start, we're going to talk about the historical context here. So in the 1960s, we see an issue with getting enough women to participate in research studies. And that's something that's persisted from a very early time, far before 1960. But there's an incident that occurs, and that's the infamous case of thalidomide. And if you'd like to learn a little bit more about this particular issue, it's something that's commonly talked about in organic chemistry classes. But I'll go ahead and link a website down in the description that talks specifically about this thalidomide incident. And I want to attempt to summarize the incident here to give a little bit of context. So in the early 1960s, a drug called thalidomide was being prescribed for many issues, including pneumonia, colds, the flu, as well as morning sickness, which is something that's particularly common in pregnant women. When thalidomide was taken by pregnant women, this particular molecule would go throughout the body. Patient was pregnant, it would enter the fetus through the umbilical cord. And what was not known about this particular drug was that it had two geometric structures. And this has to do with a particular property called chirality. And what we find is that while one structure, the one that was intended to go to the patient, treated their morning sickness, the other version of that same molecule would cause severe birth defects. And so there were a plethora of patients that were taking thalidomide that ended up having children that had very serious birth defects. That included causing neurological damages, issues with the development of appendages, and many people ended up having serious birth defects as a result. So in response, the FDA went ahead and made an announcement, and they placed large limitations on the enrollment of women that they deemed of reproductive potential in research. And that was with the intention of protecting them from potential side effects of the drugs that were trialed. So as a result, women were largely excluded from research, and progress was set back for decades. This lasted until 1996, when the NIH Revitalization Act was finally passed by Congress to require the inclusion of women and minority groups in research. So I find this really ironic because in an attempt to protect women from issues that could result from taking experimental medications, they ended up causing a huge issue with underrepresentation of women in research. And there's still a lot of progress to be made in this particular issue. So in the study that I mentioned, they reviewed clinical trials from 2016 to 2019, and they found that only about 41.2% of all study participants in clinical phase 1, 2, and 3 trials were female. So we're missing about 10% of enrollment in these studies. So while we've made some significant progress, we're still seeing some of the effects today. So this kind of lays the groundwork for issues and disparities that we see in healthcare. So I think that this leads us straight into our next article. And that's going to be, how do we treat our male and female patients a primer on gender-based healthcare inequalities. This article talks specifically about misdiagnoses as well as a difference in treatment for both male and female patients. So we're going to go ahead and start with misdiagnoses. And this article says that there are many diseases in which the first diagnosis, the initial diagnosis of someone with a disease, is typically going to be older for women than it is going to be for men. And this is a really significant issue because the time at which you're diagnosed can have several implications that can result the progression of that particular illness if it is time-based. And there's also clinical outcomes that may be affected by waiting longer to get your diagnosis. So these are prominent issues that result from later diagnoses. So there are several specific things that this article states for problems that can contribute towards this. That can be lower screening. One example that they gave was HIV screening, typically being lower for women. Also, assessments that they give to patients and testing. That includes things like alcohol use disorder, which is not assessed for as often in women as it is for men. And there are various other examples that they gave. One of them I thought was really important to bring up is the example of heart attacks. So, in men, we have some typical symptoms that we expect for male heart attacks. That includes pain in the chest, and that pain may radiate towards different parts of the body, like your arm or your back or your jaw. So that's for a male. And while these may also occur in women, the symptoms that women generally face for heart attacks can be a little bit more vague or broad. And that can lead to some crucial misdiagnoses. And this gives root to something that was coined in 1991, the Yentl syndrome. So this was a term that was coined by Bernadine Healy in the New England Journal of Medicine. And I went ahead and found the article. It's down in the description as well, if you want to read it. But I want to go ahead and define it for you all, as Healy had done in her article. So, Yentl syndrome, and that is once a woman showed that she was just like a man by having severe coronary artery disease or myocardial infarction, then she would treat it as a man would be. And the problem is to convince both the lay and medical sectors that coronary heart disease is also a woman's disease, not a man's disease in disguise. Neither woman nor their physicians fully recognize that myocardial infarction is the leading cause of death among women in the United States. Moreover, all too many research studies of prevention, diagnostic methods, and intervention for coronary heart disease have been conducted in exclusively male populations. And, it is important to consider this was published in 1991, 2 years before the NIH Revitalization Act. And while we did say that there has been progress made, there is still more progress to be made. So I think that this is a really fascinating article that has some really interesting components, including the etymology or the roots of this term and the issues that were present in 1991, but are still present today. So you can go ahead and look at that down in the description of this episode. There were also some other videos that I used to learn more about this issue. And those are some of the ones that I mentioned earlier in this episode. So you can also see those in the description. So while there are issues with misdiagnoses, there are also issues with treatment. This article also talks about the prevalence of ACL injuries, for example. Women are 2 to 9 times more likely to sustain ACL tears than men are. And despite these higher rates, men are more likely to undergo reconstructive ACL surgery than women. There's another study that was published. It's called The Effect of Patients' Sex on Physicians' Recommendations for Total Knee Arthroplasty. And in this one, women are considerably more likely to be diagnosed with osteoarthritis of the knee than their male counterparts. This is a true fact. However, the odds of an orthopedic surgeon recommending total knee arthroplasty to a male patient was 22 times greater than for a female patient. And they also found that 93% of physicians claim to not consider sex as a part of their medical practice. And I think that this brings to light some of the issues with implicit biases. And this is going to be something that's pertinent throughout a lot of social determinants of health, a lot of minority groups is this implicit bias. And it's essential to be able to check that, recognize it, and act accordingly. So, yes, I thought that these articles were really important because they discuss misdiagnoses and disparities when it comes to treatment of patients. There are several other articles that I wanted to go ahead and tell you about. The first one is called The Population-Wide Analysis of Differences in Disease Progression Patterns in Men and Women. And this is a Danish study that had an incredibly large patient sample population. It has information that pertains to patient admissions of almost 7 million patients. And the article contains lots of information about inequities of healthcare that pertain to the female health gap. Another article titled How Healthcare Fails Half the Population, an investigation of gaps in women's healthcare, is published on the Berkeley website. It introduces the concept of femtech, which is a movement for technology-based women's health solutions. And this article also provides a comprehensive view of issues that are prevalent in many facets of healthcare, education, and research that require revision to address the needs of women. So I recognize that there are issues issues that are present here and many that I didn't even bring up. But I do want to mention some of the solutions that have been potentially proposed for addressing at least a couple of the issues. So the first one was the use of individualized patient care. And what that means is to treat each patient individually, to understand and be open to consider that each patient is different in many ways. And what that entails is understanding your own implicit biases, checking them, correcting them, and then acting accordingly and treating each person individually. Those are some of the solutions that were proposed. I'm sure there's some other solutions that were certainly proposed in some of the articles that I mentioned. I think that femtech is one of the ones that really poses a lot of opportunity for the future in improving the disparities that are present in women's health. And if you are interested in learning more about these topics, let me know in the comment section below. I would love to do a deep dive on anything that was covered in this episode or any other episode where I discuss hurdles in healthcare. So thank you very much for listening. Please go ahead and leave a like, comment, and subscribe or follow on whatever platform you're on. And thank you very much. I hope you have a great rest of your day. Bye-bye.